This lecture is about the lumbar area. It's more of a miscellaneous lecture just to pick up bits and pieces that didn't really fit into other discussions. So we're going to break this lecture into three big groups. We're going to talk about diagnosis of the lumbar vertebra, we're going to talk about large muscle groups and how to treat with myofascial, and then we're going to close out with a very important muscle, psoas. So we're going to start out with how to diagnose the lumbar spine. So the way that you're going to do this is the exact same way that you diagnose the thoracic spine. So you're going to assess for rotation in neutral, you're going to assess for rotation in flexion, extension, use Friat's laws. It's exactly the same as thoracic spine. So that's the first block of this lecture. Lumbar spine is the exact same as thoracic spine. So then we're going to move over to muscle groups and how to treat with myofascial. You can use myofascial technique to treat many different muscles, but the easiest way to go over an example is going to be the large muscles of the spine. So to do that, we're going to first draw a picture. And this will give you an idea of what we're talking about. So the large muscle groups that we're going to go over are the erector spinae, and this includes spinalis, which runs closest to the spine. This includes longissimus, which is the next muscle lateral, and this includes iliocostalis, which is the most lateral. Then you have multifidus, which runs close to the spine but is the deepest of the muscles that we're going to discuss. And then you have quadratus lumborum. So the reason that we're going to name these muscles is so that we can go over how to use myofascial technique to treat it. So let's say that we have a dysfunction in one of these muscles. When one of these muscles is dysfunctional, it's going to become hypertonic. So if you think about what these muscles originally do, they're located on the posterior side of the body near the spine. They're going to assist in extension of just standing up straight. So we're going to use these muscles to talk about how to use the myofascial technique. And this is a good time to remind you that OMM is a lot about learning the concepts of treatment. So myofascial is not necessarily the best way to treat these muscle groups. It's just one way that you can treat them. If you want to think up a way to use muscle energy, that's acceptable. If you want to use counterstrain, if you want to, then that's acceptable. But this is an easy group to talk about how to use myofascial. So the idea behind myofascial is that you're going to balance the tissue in three planes of motion. You're going to use traction, rotation, and compression. So you're going to palpate the back of where the muscle groups are, and you're going to add linear traction either along the muscle or parallel to the muscle, you're going to include rotation of the muscle, which is just like a clock face, clockwise or counterclockwise. And then you can add compression to the muscle to really engage the tissue. If it's a superficial muscle, you don't have to use as much compression. If you're talking about a deep muscle like multifidus, you may need to add more compression to engage the tissues. So which direction do I move the tissues? So as we discussed in one of the previous lections, myofascial technique can be direct or indirect. Remember that direct means engaging the barrier, and indirect means engaging the freedom, or doing what the muscle can do. So for our example, these muscle groups induce spinal extension. So if these muscle groups are hypertonic and the origin and insertion come closer together, that's going to be into extension. So the freedom of motion for these dysfunctional muscles will be extension. The barrier will be what they cannot do, which is elongating the muscle into flexion. So if we're going to engage the direct barrier, for this example, that means that we're going to push into flexion, or we are going to elongate the muscles. The way that we're going to do this is add traction, rotation, and compression to the muscle in order to elongate it, or until we feel a hard end feel during treatment. Now we're going to do the opposite of that for indirect. We're going to engage the freedom, meaning that during our traction, rotation, and compression, we are going to move the muscle into the position of ease, or the position where it wants to go to the freedom. So as we're doing this, we're going to know we're in the right spot when the tissues feel loose under our hands after we've applied the 3 planes of motion. Also, as we discussed in one of the previous lectures, myofascial technique can either be active or passive. And the way that this is going to come into play is by using enhancers. Enhancers is another way that you can change the technique in order to best fit your patient. So if we're going to use enhancers for this treatment, I'm going to set the patient up into the 3 planes and either engage the direct or indirect barrier, and then I'm going to ask the patient to flex the muscle groups. So I'm going to ask him to extend his spine to engage these muscles. That's going to be your enhancer, and that makes it an active technique. If you are going to use enhancers for different muscle groups, you're just going to have them engage whatever muscle you're treating. So if you're doing myofascial to the diaphragm, you're going to ask the patient to inhale and exhale to engage the diaphragm. So once that you have the patient in the correct barrier and you are using enhancers or not, you hold until you feel a release. Now the release can be one of many things. It can either be a warmth feeling, it can be a rush of fluid, it can be the tissues melting under your hands or becoming loose. You just hold it until you feel that feeling. Once that you're there, you can release the 3 planes of motion, return to neutral, and always rescreen. For any treatment that you do, regardless of if it's myofascial, muscle energy, counterstrain, whatever, when you're done with the treatment, you have to rescreen to assess for efficacy. So now we're going to leave myofascial behind. And this is part 3 of the lecture. This muscle is a board's favorite. It always shows up. It's the psoas muscle. An important concept to understand is where the muscle originates and where it inserts. This can give you a lot of information on what the muscle does and how you can best treat it. So the origin of the muscle is T12 to L5, and the insertion is the lesser trochanter of the femur. So if I'm going to draw a picture of where this muscle is, where this is the sacrum and this is the spine, it's going to attach to the lesser trochanter right here. So what's the action of this muscle? Well, if you think about it conceptually, when a muscle contracts, it just brings the origin and insertion of the muscle closer together. So if you know that the origin is on the spine and the insertion is on the lesser trochanter of the femur, and you contract the muscle, you're going to induce hip flexion. And it can also induce very slight external rotation of the leg. So what do you have if the muscle is dysfunctional? How do you tell in a patient? What are some of the findings that you'll see? So if it's dysfunctional, the patient may present with lower back pain. If you imagine that the muscle is hypertonic and they're constantly contracted, they may have some lower back pain. Easy one. The next one that you will see is a pelvic shift. So to demonstrate this, I'll do another picture. So here's your sacrum, here's your spine, here's your femur, and the psoas muscle is now hypercontracted. This hypercontraction leads to the pelvic shift. So if this is contracted on the right side, you can imagine that the patient's pelvis is going to be shifted to the left. So if I'm going to demonstrate this, if my right psoas is contracted, making me lean this direction, my pelvis is now shifted to the left. Another finding that you may see is gait dysfunction. So as you can imagine, if someone has a pretty severe pelvic shift and they're stuck in this position, when they're walking, they're going to have to compensate for that shift. So they're going to have some sort of gait abnormalities. Another thing that you may find is an increased lumbar lordosis. As the psoas contracts, it's going to change around your lumbosacral angle. And this lumbosacral angle can also be called a Ferguson angle. This angle basically explains how tipped forward your sacrum is in relation to your pelvic anatomy. So the more that you dip into flexion, the more intense your lumbosacral angle will be, which will then include an increased lumbar lordosis. Another finding that you'll see is a positive Thomas test. A Thomas test is when you have a patient laying on the table supine and they have both of their legs dangling off of the edge of the table. You ask the patient to raise one of their legs up and bring their knee close to their chest. If the other side psoas muscle is dysfunctional or contracted, the other leg will passively come off the table as well. It's going to be pulled off the table by this hypertonic psoas muscle. And one final finding that you're going to have is spinal dysfunction. So as you can imagine, since the origin of the psoas is on part of the spine, if it contracts, it's going to induce flexion, rotation, and side bending ipsilaterally. so to the same side of dysfunction. So what can cause one of these dysfunctions? There are a few different ways that it can happen. One way is by bending forward. So let's say that you have a patient come in, he's having gait dysfunction in a positive Thomas test. He also explains that he's a carpenter and he is constantly bent over his work table for long periods of time. That excess bending forward can induce a psoas dysfunction. Another cause of dysfunction can be if you activate the muscle too quickly, as in getting out of a chair. Imagine you're calling your grandpa sitting at home. He's sitting in his chair, he hears the phone ring, and he jumps up because he's so excited. That quick jumping motion can cause a psoas dysfunction. So not only can you get a dysfunction through movement, but you can also get a dysfunction throughout other body organs. So one test favorite is ureteral calculi. If you think about anatomically where the ureters lie, they run over the psoas muscle. So if there is a calculus found inside of the ureter and it starts to become inflamed and bother the tissues around it, it can cause a psoas dysfunction. Same concept behind diverticulosis. So we have the patient, we have how to identify it, and we have what causes it. So how do we treat it? So once again, you have to bring up concepts from the past. So you can treat this using multiple different strategies that we have learned in the past. You can use muscle energy. You just have to remember how muscle energy works. So you stretch the muscle, engage the barrier, ask the patient to isometrically contract. If you want to, you can try and use myofascial. It may be difficult to use myofascial because you're not going to be able to compress the psoas muscle as well without squishing their organs. Or you can do everyone's favorite counterstrain. Remember, counterstrain is an indirect technique. That's why we're going to write it in blue. So if you want to find the tender point, you have to know where the ASIS is and where the umbilicus is. Once that you know where these two landmarks are, you then have to travel 2/3 of the distance between them and palpate deep. That's where the tender point will be for the psoas muscle. Now, if you want to treat it using counterstrain, what do you have to remember? Fold and hold. So the easiest way to think about fold and hold is put the muscle where it can go. Do what the muscle does when it contracts. So what does the muscle do when it contracts? It goes into flexion and it externally rotates. So if you're going to treat using counterstrain, flex the spine, side bend the side towards the muscle, and if you need to adjust a tiny bit, you can induce a little bit of external rotation of the leg. So once again, applying this to what we know about what the muscle does, the muscle flexes the spine, side bends the spine towards the side of dysfunction, and slightly externally rotates the leg. So that's the exact position that we're going to put it in because this is an indirect technique. So this lecture was a grab bag. We went over 3 big topics. We went over how you diagnose the lumbar vertebral segments. It's exactly the same as the thoracic vertebral segments. We went over the large muscle groups of the back in order to give an example of how to use myofascial technique. And we also went over the really important muscle of the psoas, including origin, insertion, dysfunction, and everybody's favorite counterstrain. And that's OMM of the lumbar area.